Hi, my name is Millie Long. I'm at the IBD Center at University of North Carolina, and I'm here with Dr. Susie Kane from Mayo Clinic. And we just finished a wonderful symposium called Timing is Everything. It was focusing on vaccine recommendations and preventive health recommendations in patients with IBD. And so based on that, in terms of the symposium tonight, Susie, I felt that it was great to really reinforce some of these preventive health recommendations in patients with IBD.
Right, and what was nice is that we had the backdrop of the ACG guidelines to start with, and so that the faculty had at the tip of our tongues and on the right at the forefront of our minds some of the really updated data and recommendations. And what was interesting then was that we could use that to then as a backdrop and then incorporate the exciting news about tofacitinib getting FDA approval.
Absolutely, and it's funny, the title of our symposium had to do with timing, but the timing couldn't have been better in that we just had an FDA announcement of the release of tofacitinib as a therapy for the treatment of ulcerative colitis. And as you and I both know, the data show great efficacy in terms of management of UC, but there is a signal for increased risk of herpes zoster or shingles. And it seemed that the audience had a lot of questions surrounding how do we deal with that? You know, what do we do with this increased risk?
Right, and so it's probably worth just taking a step backward first and talking about what we know about the availability of vaccinations for herpes, who's at risk, what are the indications, and what's the practice, and then how do we then interpret what we already know into what we're seeing in now the updated evaluations of the OCTAVE data.
Yes.
So we know that patients with IBD are at increased risk for herpes.
Yes.
Already the baseline risk in the US is 1 in 3.
Right.
So you cannot ignore this in any of your patients, regardless if they have IBD or not, and regardless of whether you're treating them with immunosuppressants.
Oh, absolutely. And, you know, we've published data that show that the risk really is across various age groups. And so you kind of think of shingles as something that happens in older individuals. But in IBD patients, this can happen even much earlier.
Exactly. So, you know, you have to be mindful of the timing of giving that. Is it before you start your immunomodulatory therapy? But I think one of the key things that came out was the CDC, or is it the CDC or the MMR?
The Advisory Committee on Immunization Practices.
Right, so, you know, what is considered immunosuppression?
Right.
So if we go back to that first and say, you know what, it's prednisone over 20 milligrams over 2 weeks, azathioprine and 6-MP greater than the doses we use. And I think that was really key learning point for a lot of our audience.
I think so too, that, you know, importantly, we have 2 Zoster vaccines available now. One is live, that is the older one, and we have a newer vaccine that's been available just this year that's inactivated. Right. And so not in all places is the inactivated vaccine available. And what becomes really important is that live Zoster vaccine, that can be given to those patients on azathioprine, on 6-MP, even on methotrexate at the doses we use. It's higher doses that are a problem. Right. And so this is an important phenomenon because there are many patients on those therapies that, you know, we certainly don't want to, you know, not have them get the vaccine that we know is effective. But importantly, the newer vaccine seems to be even more effective.
Exactly.
Which is great. And so the newer vaccine is an inactivated vaccine, so we don't think it has a risk of live transformation. And this vaccine, it's given in 2 doses. So it's 1 dose and then a second dose anywhere from 2 to 6 months later. Right. And it really seems to confer great protection, like, 95+% protection.
Pretty amazing.
And so with this vaccine, hopefully it'll help not only our patients with IBD, but, you know, other individuals as well, because the vaccine recommendations really say everyone over the age of 50 should be getting this vaccine. Right. But certainly in my practice, one of my take-home points is I really want to make sure I'm giving that vaccine to all of my patients over 50, regardless of what medications they're on.
Right. So a lot of the questions and discussion then was, okay, you have the patient under 50.
Right.
What are you going to do now? Do we have enough data? Do we have enough comfort level? You've already said that, you know, that what we do know about the vaccine is how efficacious it is and how seemingly safe it is.
Right.
But it's ironic that it takes the inactivated virus vaccine to show us that we can actually give the live virus vaccine to most of our patients anyway.
Right.
And so that it's just in terms of the timing of something else coming along, to put it into our minds that, look, this is a condition that we really need to do primary prevention for.
Right.
And vaccinate and prevent.
Absolutely. And right now the vaccine is really only approved for people over the age of 50. Right. That was the group that it was studied in. One of the reasons is everybody over the age of 50 has previously had chickenpox for the most part.
Right.
This was prior to varicella vaccine, and so they're at risk. And also, we don't really know what the longevity of these vaccines are. And so we do know if given over the age of 50, you're probably not going to need another dose.
Right.
But we don't know in those younger age groups. And so one of the things that came out today, we had such an expert panel between yourself, Gary Lichtenstein, and Gil Melmed, who all wrote the preventive health guidelines. And it seemed that everyone was of the same accord that we're giving that vaccine to everybody over 50. But in younger patients, you really have to talk to them about it.
Right.
You have to talk about, risk-benefit ratio, that it hasn't been studied in younger populations, and kind of come to a decision from that regard. That's not something that we would say it was contraindicated, but it's just something we got to talk about.
Exactly. So that we can certainly open the door to that conversation and encourage the discussion and the thought that, hey, we should be thinking about primary and secondary prevention, and that maybe cost is an issue. I guess personally, I don't know how much it costs for the two
and I've heard
doses.
that, in the neighborhood of $150 to $200, ish for the vaccine.
Which for somebody who has had shingles, out of, just personal disclaimer, that $200 is worth that horrendous experience that I had. So I would do it. But I certainly will have that conversation. It's also a matter, though, I hear that there are certain parts of the country where it's been so popular you can't get it. Right,
exactly. And so I think that hopefully that problem will improve as we get better distribution. But we do have that other live vaccine that is available. And again, if someone's on immunosuppression with azathioprine or methotrexate, it can be given. But certainly there's still a black box warning if someone's on an anti-TNF agent.
Right.
And one could extrapolate from that other biologic agents as well. Although, I think that that needs further study, and that some of our biologic agents, particularly, our anti-integrin therapies, those are more gut specific, and I think further study may tell us if other vaccines could be given on those therapies.
So getting back to what we started the conversation, now that tofacitinib is FDA approved, what are you doing because of that, observation that perhaps that there's a signal for an increased risk for herpes zoster in that?
One of the things I'm doing is, so I am using a little bit of tofacitinib already, just off-label. And what I am doing is I am really counseling my patients that this is a risk, because I want them to let me know if they start having pain, because the pain often comes first before the blisters. So let me know if this happens, because I'm going to want to treat them very quickly with an antiviral therapy, but also just that awareness so that they understand that risk. And then if they're over 50, I am giving them the vaccine. Actually, one of the things that we as a panel were talking about earlier is what are our practices in our own clinics. And in my clinic, I actually we stock the inactivated shingles vaccine. So we give it, and particularly, I'm trying to give it to everyone over the age of 50, but certainly for those people over 50 whom I'm starting TOFA, I'd be giving it. And then I'm having a conversation with those younger people about whether or not we think that they would want to have the vaccine, given that we don't have specific data in their age population.
Right.
Is that what you're thinking as well?
Well, because I practice at such a tertiary and quaternary practice, and we don't do a lot of primary care, we do not have the infrastructure for actually vaccinating any of our patients, whether it's the transplant group, the IBD group. Okay. It's interesting, we send them to not the infusion center, but it's the immunology vaccination clinic.
Oh, great.
So we write a prescription for the vaccine we want them to get. They go to the pharmacy, get it, and then they have an appointment in the vaccination clinic, and they just bring whatever therapies we want them to get, and then it's administered there.
Oh, that's great.
So we have a mechanism in place, but it's not an easy system to try to get through, and sometimes insurance won't cover it if they're trying to do it through a Mayo Clinic, but they'll get it through their PCP.
Okay.
It turns out that Wisconsin is excellent at tracking all vaccinations for their residents in the state.
I saw that. So I was at a presentation this morning where they mentioned that you can really look up everybody in the state of Wisconsin who's had a vaccine. We're not that good in North Carolina.
So that was I think I was doing that on purpose to segue into maybe what did come up just in brief was the research that was presented that we were able to talk about. Again, timing of some new data in regard to the influenza vaccine.
Right. No, absolutely. So Freddie Caldera did a great job. He presented a randomized controlled trial that actually was in a population of patients on monotherapy with anti-TNF agents. And they were randomized to either the standard influenza vaccine, which is what most of us are giving, as compared to a high-dose influenza vaccine. And the premise behind it is that some data have shown, some of Gil Melmed's and others' data, that there's a blunted vaccine response in people on TNF. And what he was able to show was that the titer dramatically responded to this high-dose vaccine to a much greater extent than that standard dose vaccine. So I think that might change my practice.
Right.
I mean, I think I'm going to go home and ask, how do I get high-dose influenza vaccine for my patients? And that's one take-home message, from just today that I'm going to bring home to my patients.
Exactly. And I think, then in my mind, the third very common infectious disease that our IBD patients are at risk for because they're walking around as human beings is pneumococcal pneumonia.
Oh, absolutely.
And so community pneumonia is a big deal, and that there is something that we can do in a primary prevention setting, which is vaccinate our patients. And so I think one of the pre-test questions was which one do you give and how do you do it? And it was just sort of reiterated in several of the talks in different ways so that people could learn it how they wanted. I'm very much a picture and cartoon person.
Right.
So I know that if you are naive to any pneumococcal vaccination, you start with the polyvalent 13 because it's the lower number.
Great way to think about it.
2 to 12 months later, you give the 23, and then 5 years later, you give a booster of the 23.
And then they're done. Yeah, no.
It's quite brilliant.
And I think that, it's such an issue in that, pneumonia is it's the number one killer of infectious, complications in the U.S. And so what we think of in our IBD patients is particularly our patients on, multiple forms of immunosuppression, they're at increased risk for the invasive pneumococcal disease, the septicemia that arises from that. And so if we can primarily prevent that with vaccination, we want to. And one of the things I've found in my practice is that recommendation, we as gastroenterologists are starting to be more aware of it, but the primary care providers aren't always. They're very tuned in. They're excellent at what they do. Diabetes, asthma, early pneumococcal vaccination, but IBD isn't always at the forefront of their mind. And so I think that to some extent, because we're prescribing the therapies, we need to at least make that recommendation to the primary care doctor and or if we have the availability to stock those vaccines, to give it, because it really can be life-saving for our patients.
Exactly, and it only takes one to really see the importance of what we do as caretakers and providers. And to say that, well, it's the job of the PCP, but again, we're the ones prescribing this. We're seeing these patients and monitoring them for other things, like the neutropenia if they're getting a thiopurine, like the liver enzyme issues with biologics. And so why should we not be keeping this and at the forefront and being the ones who are doing the prevention and disease along with the disease monitoring? It just makes sense.
Absolutely. I mean, it seems like even just in our conversation today, we hit 3 really good take-home messages in regards to vaccination. So there was a new study that showed that high-dose influenza vaccine may be better in patients on immunosuppression with TNF. So I'm going to look into that when I get back home. Secondly, Zoster. There's a new inactivated vaccine. There's a new drug coming out that may have an increased risk of this. I need to kind of define my practices so I can make sure my patients are immunized against Zoster. And then thirdly, the pneumococcal vaccine. That this is kind of a forgotten vaccine, but a real problem and a real complication that we can make some recommendations to our primary care provider. And I love your lower number first, 13, 23, and really recognize that both are important. They complement each other and they cover different, different valence. So.
Exactly. And I mean, and the patients are seeing these commercials. I mean, Prevnar is what you see the commercial for pneumococcal. They've got an older patient who then is, sidelined by horrible pneumococcal pneumonia, and it's completely preventable, and you don't
Right.
want people dying.
No.
That it's ironic because we did spend some time talking about, cancers.
Oh yeah, we did.
And that, that it's secondary prevention in that scenario, and that you have to have the discussion about lymphoma and the skin cancers and colorectal cancers, and then the cervical dysplasia and anal cancer. So it was quite a potpourri of different cancers, but that when you talk about the risk of cancer from the therapies that we're giving, that the risk of dying from a preventable infectious disease is so much greater, and that they're all worried they're going to get cancer and don't even realize that they could die of something simple or common like the flu or pneumonia.
Right. No, absolutely. And it makes you realize there's so many things we have to address. And I obviously do this in layers with my patients. And I kind of wait for those, the case example you used, kind of a well visit to really kind of, okay, you're doing well in your therapy. We've got to address a lot of these other things. But I think by addressing it, it really improves those outcomes for that patient. And so we went through this whole gamut of prevention. And really in my mind, when I'm talking to a patient about therapies and complications, I really want to emphasize those parts that are preventable. And so you mentioned skin cancer. So sunscreen use, can really, we think that the mechanism for azathioprine-induced non-melanoma skin cancers is actually photosensitivity. We did a study where we did light testing on the arms of people, where we did it before starting the azathioprine and after, and we showed that after they were started the azathioprine, it took less kind of light frequency to give them a light burn. So it really does seem to be potentially a preventable complication. So wearing sunscreen use, thinking about the secondary prevention of the dermatology screening exams, all that becomes very important. There's also an increased risk of melanoma with anti-TNF agents in particular. And so that's some reason to put someone in a screening protocol, because we obviously want to catch that earlier if we can. But so we want to talk about some of those risks, the preventable aspects, and then we also want to talk about some of the benefits of our drugs. You did touch on colon cancer as well.
And the fact that we are mitigating active inflammation, which may be driving some of the pro-neoplastic or pro-dysplastic changes that are occurring, and then it becomes secondary prevention.
Because we're really trying to prevent that malignancy from developing by treating the underlying inflammation. And then, some, unfortunately, of these risks aren't preventable, but we just have to have kind of a shared decision-making conversation with our patients about what some of those risks are. One example is the lymphoma risk that we do see, both with anti-TNF agents and with thiopurines. Actually, there was a very nice paper that came out in JAMA just this past year that was the first paper to really be able to look at risks in people who had just been on a TNF. So many other studies, people had been through thiopurines, they might be on combination therapy, so it was hard to tease out what's the risk of the anti-TNF and what's the risk of the thiopurine. And so this French paper, actually, because they had all of the drugs they were given through the French national insurance, they really could look at a pure TNF population and did show, an increased risk. It's about a twofold increased risk. But I think that's just important to counsel our patients on. And some of the same the French have also demonstrated that while there's an increased risk with azathioprine, once you stop that drug, that risk goes back down. And so it's not that they've really accrued risk forever. And so I kind of use that when I'm counseling my patients. Again, we talk about some of the preventable stuff that can occur when we're starting some of these therapies that we can prevent, try to vaccinate them, these things we talk about. But then the other thing I mentioned is that, for example, if I'm using combination therapy, I'm probably not going to use it forever. The idea is get them into remission, and then if I pull back off that thiopurine, then that lymphoma risk goes back down to where it was before the thiopurine was started. And so I think that can be somewhat reassuring to a patient when starting the therapy.
And what was interesting is that we did have the discussion with Gary too. He pointed out that it's really that the sweet spot for maybe using the thiopurines is those over the age of 35 and before 60, because it's the over 60, you're sort of worried now about the lymphoma and really increasing that risk for their skin cancers, and that perhaps you're going to get away with the biologics alone. You're not going to need the combination therapy. And those below 35, particularly the males, are going to be at risk for hepatosplenic T-cell lymphoma, which is fortunately very rare, but very serious.
Absolutely.
And so In the younger population too, then we talk about males and females for HPV.
Oh, yeah, exactly.
Prevention, and that we do suggest that women with IBD who are on immune suppressant therapy, particularly thiopurine, follow the guidelines for more frequent pap smears and cervical cancer screening.
Okay.
The data are mixed about cervical cancer in terms of an increased risk, but certainly all of the papers do say that there's an increased risk for cervical dysplasia, and that hopefully that with secondary prevention with these pap smears that you are preventing cancer. You may find the dysplasia,
right,
but that you go to a LEAP procedure or more frequent screening,
right,
and then they are preventing the cancer
right,
because they're finding the
they're
dysplasia
finding it before it develops,
and that risk, because it's driven by HPV,
right,
whether it's cervical or anal, that it's the thiopurines because of the interaction with the viruses and not the anti-TNFs. It doesn't appear that any of the other biologics either are in that signal, but just the thiopurines.
So Susie, when you're trying to primary prevent this and give the vaccine, do you give it to men and women?
Yes,
just women?
absolutely.
You do give it to
absolutely.
men and women. Okay.
Absolutely. And I think that there's, again, very effective direct-to-consumer. You see the commercials with the young gentlemen saying, how come you didn't know mom and dad, and now I've got anal cancer.
Right.
And that it was preventable.
Right.
It's not going to be one of those topics that's going to be,
Mm-hmm.
discussed in a really public manner, but it's certainly primary prevention.
Absolutely.
That we can keep these very sad stories from happening.
No, and the vaccine was also studied in patients with IBD, and it showed that they responded appropriately to these titers, and they didn't have any increased risk of a flare or anything else.
Right,
and so
exactly.
This should be considered just as safe as in the general population.
Exactly,
right?
and I think that's a really good point. The other vaccines have also been shown to be safe in the IBD population, so they do not flare. So, we have patients who say, well, I'm really worried about getting vaccines because even if it's an attenuated virus, it may make me flare, and that we just don't see that.
Not to date, but there's some concern about the new one though, the new Zoster vaccine. Not that it will do it, but that again, it hasn't been studied broadly in autoimmune populations. And so I think probably I would still give it. I still have. I've given it to patients with IBD and I've had no issues. But I think that it would be important to study it. And it'd be nice to have that same level of data that we have for all the other vaccines.
And I'm sure that it's already on Gil's to-do list.
I'm sure.
So let's just stay tuned for next year's DDW, and I'm sure there'll be a paper.
And one of the throughout this conversation, Susie, it seems that both you and I have really been emphasizing kind of two forms of prevention. Primary prevention, that's really preventing disease from occurring. So these are these great vaccinations that we're talking about. And the secondary prevention, the pap smears that patients need to have, the skin screening exams that patients need to have, those things to detect disease early to help to prevent that downstream complication. But the other thing I always think about with my IBD patients is tertiary prevention, which that refers to actually treating the disease to prevent downstream complications. And so, in other words, treating the inflammation, helping to prevent structural damage to avoid that surgery from IBD that causes disability, et cetera. So we can really frame the whole treatment of the IBD patient, in terms of all of these forms of prevention as things we should really have on the forefront of our minds when we're treating these patients. Not necessarily all in one visit, but in a series of visits,
but like, as you said,
layered.
And it becomes, the case that you presented was a 22-year-old who had active disease. The case that I presented was the 60-year-old who was well. And so, we had the luxury of time to talk about other things, like bone health. We didn't even touch on that. And then the skin cancer, and then also depression.
Oh, that's a really good one to bring up. Yeah.
So we know that depression is prevalent in the U.S. population, and it's certainly prevalent in our IBD population. And that I believe that it was Gary that showed us the data about the 2-question screening exam.
Yes, very simple.
And you can do that as you're examining the patient. It doesn't have to be a separate part of the visit. It can be while the patient is getting onto the table for, a physical examination. So tell me, have you been feeling down or, lost interest in anything over the past month? And that then keys, okay, hey, you know what? That was my primary screening and I better,
Right.
refer this patient or have some sort of discussion about what we should do about that.
Well, and that could, not only do we need to address it for our patients' sakes, but, we and others have shown that depression can be a factor leading to exacerbation of inflammatory bowel disease.
Right.
So you can almost think of it as a tertiary prevention type thing, where not only are we screening for it, we need to treat it, we need to have this patient not be depressed, but that it can play a role even in terms of the IBD itself.
Right, exactly.
Well, I think that now that we've had this conversation, I'm realizing we took on a lot at this symposium, and we kind of went through this whole journey of a lot of really important things. I think that one thing I'd love to leave people with are some take-home points for what they could do tomorrow in their practice.
Right.
I don't know. Do you have a top 2 or 3?
Well, I think you already said them, and I think it's worth emphasizing the 3. So, hey, you know what? That there is a high dose influenza vaccine.
That's great. I'm going home and checking that out.
That we now have an inactivated Zoster vaccine that over 50 is indicated, and so that is at the forefront of, hey, you know what, this is now, whether you're on an immunomodulator or not, if you're a patient in my practice, you're getting it. If you're over 50,
button. You're 50,
easy button.
You get it.
Exactly. And then it's getting late in the hour, so I can't remember the third one, but it's pneumococcal vaccine. Exactly. That it's the 13, then the 23, and you're done. And you've prevented morbidity as well as potentially mortality.
No, that's perfect. I agree. And then if I had to do 2 in the preventive realm, I would say sunscreen use, a primary prevention for skin cancer. And then likely the other component would be the depression screening.
Yeah.
I think that really plays a role. And it's something I could go home tomorrow in my practice, like you said, while I'm examining the patient, and really not add time to my day, but could potentially really improve that patient's quality of life.
And maybe we can add one more just to make the clinician look smarter and the patient feel better, is that this azathioprine or the 6-MP that they're on is temporary, it's conjunctive, it's combination therapy, and guess what? Your risk for the skin cancers and the lymphoma will go down if we stop this.
Right, exactly. This isn't forever. This is to maximize your therapy, and that risk goes back to baseline. I think all of those are great talking points you can use with your patients to help you and them to come to a shared decision about what the right therapy is for them and what we can do in a preventive fashion to mitigate risks. So. Well, it was a pleasure working with you on this symposium.
It was
great.
Fabulous.
It was a fabulous symposium, and I hope that the audience enjoyed it, and I hope that the people will be able to review the slides, and really take home some of these messages to their practices.
Exactly.
Yeah.